Well, thanks very much for joining us. I'm Jeff Fernie. I'm the Cray Family Chair in Prevention and Healthcare Technologies at Toronto Rehabilitation Institute. Why are we here? Well, Canada's not doing so well in healthcare. We feel superior, I think, quite a lot because we're always ranked above the US, which is just to the south of us, quite a long way above the US, but we're actually very low in developed international countries. We've recently been ranked as 10th overall of 11. And there are particularly large income-related inequities that are evident in Canada. Our health outcomes actually are rated as 10th, probably because we spend less on social support, so we're doing less prevention, and we're having to deal with the consequences of poor health care. Also, our administrative burden is rated as very, very high. We're not very efficient in providing health care. When you look at the crises we've had in long-term care, and you look at the money that's going to have to come to fix that, it's huge. I mean, it's reckoned that we're going to bring in another 40 billion, but if you read some estimates, it could be as high as an extra 71 billion by 2050 and another 27 billion extra in unpaid caregiving. This would mean over a quarter of the income tax revenue in the country. We can't go on like this. Everyone accepts that we're going to have to transfer more money from the federal government to the provinces because it slipped behind. The idea was originally, I think, a 50-50 split, and now the federal government in Canada covers about 22% of healthcare. Don't know where the money's going to come from, but obviously there's a need for a lot more money to come across. And we're not going to talk tonight about which party can do it and where the money's coming from. Our concern is that if it's just a transfer of money and we continue to provide healthcare the way we're doing it at the moment, with all the inefficiencies, we're not going to catch up. We're simply not going to manage to improve healthcare enough to reduce suffering enough. And we're just going to drive the country into more debt. So our focus tonight is on how we can make the system more efficient, how we can reduce suffering, which, by the way, has increased a lot because of the cancellation of surgeries and care during COVID, and how we can get rid of some of the inequalities in our healthcare system in Canada, which are very, very noticeable. I'm going to introduce each of our panelists when they first talk, so that we remember who they are. But I will tell you that they're all frontline providers of healthcare. They're academics as well, but I've emphasized to them that this is not an academic webinar. I want to hear their experiences in the front line. I'm happy to hear some stories, anecdotes are fine, and their recommendations on where we should go. I want to draw from their frontline experience. Now, I've provided them with a list of questions to get us moving through the system, but they don't have to stick to those questions exactly. And I'm happy for people to contradict each other. I'm happy to encourage argument, and I look forward to that argument. So I'm going to first of all start with a question for Josh Mayich, Dr. Josh Mayich. And I'm going to introduce him to you. He's the president of the Island Hop Company Limited. He's an owner of Darling's Island Farm on Prince Edward Island, and he's an orthopedic surgeon. So here's a guy who's both a farmer and an orthopedic surgeon, and perhaps he can tell you a little bit about himself before he addresses my question, which is, while access is understandably top of mind for many Canadians, there's another vital dimension to healthcare performance. How good is the quality of healthcare once Canadians do access it? So that's my first topic for Josh. Over to you.
Thanks for the introduction, Jeff. Yeah, my name is Josh Mayich. I'm a orthopedic foot and ankle and trauma surgeon. I currently work in Yellowknife, Northwest Territories, and Bathurst, New Brunswick, serving both of those underserviced communities. And yes, I do run a HOP and hazelnut operation on PEI because of my family background. So the question you're asking is probably one of the hardest questions to answer, but it's certainly a really important one. One that I'm going to answer with a bit of an analogy. So as a trauma surgeon, my typical clinic in Bathurst, which is limited. So the clinic space I get is clinic access I get is quite limited. So I'll get between 12:30 and 4 o'clock with all of the clinic staff reminding me constantly that everyone wants to go home when clinic time is done, and the managers don't have time to pay overtime. So when my clinic time is done, I need to be done. And it's pretty typical for me to have anywhere between 30 and 50 patients to see during that time. So you could definitely say, if you're those patients, you have access to orthopedic, trained orthopedic trauma care. But then you realize if you divide that period of time between 12:30 and 4:30, that's not a lot of time when you divide it by somewhere between 40 and 50. So I would say that in that circumstance, although patients are getting access to care, the quality, unfortunately, is not very high. I've got to look at their x-rays. I got to consider their past medical history. I got to consider, different elements that might be unique to a patient. Do they have rheumatoid arthritis? Do they have issues with opioids, for instance? And, in a recent case, I had a patient who suffered a severe injury to his knee called the tibial plateau fracture that was high energy as a result of an overdose on narcotics, and was kind of doing a bit of a stunting behavior. So taking the time to know how to manage this guy's postoperative pain in a way that doesn't increase his risk of running into difficulty with the medications he requires. I can't do that in 3 minutes, but that's the time that he's been that I can realistically spend, right? So here's a guy who the system is failing him on multiple levels. He can't get access to mental health care, all these sorts of things. He's coming in to see me with this more complex issue, and I don't have the time to be able to make sure that he's well cared for. So here's a guy who does have access to care, but the quality is relatively poor. And this is just one, I live in a very narrow world, right? There's I know my friends in psychiatry, family medicine, obstetrics, gynecology, all have very similar experiences. So this is an area where just because you can tick the box and say, yeah, I saw an orthopedic surgeon for my fracture, doesn't mean you were well cared for.
So I've got a second question for you, Josh. Canada spends more money as a percentage of GDP on healthcare than 9 other OECD countries. So why do we rate so low? Why is this? I mean, how come Norway doesn't have just 3 minutes of orthopedic surgery consultation? What's different about Canada?
I just think it's the way we prioritize our spending. I think we prioritize spending in a way that isn't necessarily maximizing the effect that that money can have. I'll I'll speak on a different example. So just this last weekend, I saw a lady up in Yellowknife who came down from one of the northern communities, um, an Indigenous patient who had was a victim of the residential school system issue. I spent quite a bit of time sitting with her and hearing her experience, which just broke my heart in like a million pieces. As a ex-military guy who loves my country very much, it just broke my heart to hear that this happened to her, and it made the whole thing a lot more real for me. She obviously has understandably significant mental health issues as a result of this horrific experience. And through her life has had multiple interactions with the mental health system in the North, which is, um, I think, grossly underfunded would be a very conservative term, um, and has had multiple interactions with RCMP and other people as a result of her understandable turn to self-medication. And what ultimately wound up happening is miscalculated in some of the drugs she was taking and wound up having a fracture dislocation of her knee. And so wound up seeing me in Yellowknife for a, treatment for her fracture of her knee. Um, you know, that's a very expensive surgery. There's a lot of rehab involved with it. It's not just about plates and screws. It's about, having an orthopedic trauma surgeon in Yellowknife and having the physiotherapists and all the care and everything afterwards. It's going to take this lady at least a year to 18 months to recover from the surgery. But when you step back and look at things objectively, you could see in a lot of ways how orthopedic trauma surgery is, so that orthopedic trauma is not random, right? These people aren't random. Trauma isn't random. It doesn't happen to everyone equally. And when you start looking carefully at discrepancies, especially socioeconomic discrepancies, you're going to find that orthopedic trauma tends to happen to people of certain groups more than others. And so, in a lot of ways, with my orthopedic colleagues, I talk about myself as being an applied psychiatrist, in that patients who have psychiatric issues that are either underaddressed or ignored entirely wind up getting themselves mixed up in activities that lead to severe trauma of the limbs, that winds up seeing me. And a very disturbing statistic that I've collected over the past 4 months in my time in Bathurst and Yellowknife, that 62% of the patients that I've seen for major orthopedic trauma surgery, so fractures of femurs and open fractures of the elbow, all requiring surgery, were either completely untreated for their mental health issue or were undertreated. This is assessed by the patient. So, and an even higher number of these people are on medications for mental health conditions. So think of how much money we've spent in treating complex fractures in 34 patients versus how much would it have cost to assist them with their mental health issue and helping them in that way. I don't know the answer to that. I don't pretend to, but just as a guy seeing it from this side and the expense, because it's one thing to say, oh, it costs this much to fix this woman's fracture. The average person that I treat is working age, and the average time off from one of these major operations, you're looking at, depending on the injury and the type of work, anywhere from from 6 weeks to 18 months off of work. So there's a tremendous opportunity cost in association with this as well. And you know, this is just one, again, just one facet that I see from my very narrow viewpoint, where we're spending a lot of money to treat a problem, where I think everyone would benefit, the patients first and foremost, from being appropriately managed upstream.
I think that this issue with mental health is also going to be one of the side effects of the pandemic. There's no question that in the patients that I'm seeing, almost everyone is just reporting how they've changed psychologically through all of this. So I think Josh is quite right that we see a lot of patients in orthopedics, particularly in trauma, who are there because they have disadvantaged circumstances, maybe socioeconomically and from a mental health point of view. But I think more broadly across the population of people we see, I see a lot of older patients in my practice, and there's no question that they are really struggling right now. So I think we've had this chronic problem that we have not dealt with effectively in our healthcare system, and I think it's going to be significantly exacerbated by the pandemic.
Thank you, Wayne. I'll introduce you a little later. Let me introduce Dr. Michael Jewett. Michael is a surgical oncologist, a cancer specialist at Princess Margaret Cancer Center, and a surgeon. He's the inaugural Farquharson Clinical Research Chair in Oncology and professor in Department of Surgery and Neurology at the University of Toronto. I've known Michael for about 40 years. He's an extraordinary guy. And Michael, the question I want to put to you is, why is innovation in healthcare so difficult? What's required to enable innovation to happen in Canada? In many ways, we have great scientists here, but we don't seem to be having as much impact on the delivery of healthcare as we should.
Jeff, I'm listening to the comments made so far, and it's profoundly depressing to me to hear the sense of frustration and exasperation in our healthcare system right now. I've been at it a long time, and I see the changes that are being described for sure. We're aging. We are now in a position where I see almost learned helplessness developing in my physician colleagues, that they don't want to see a new patient because they know they can't see that patient for a while, or more importantly, if they decide some interventions necessary, they know there will be a long delay in getting it done, and then they have the responsibility of holding the line during that time while waiting. The flip side is that there's never been a more exciting time in healthcare, and that keeps my fontanelles pulsating, as they, I hope, have always been. And if I could start again, I would do that. And what is striking to me is how little real disruption there has been in healthcare over the time I've been involved in it. It is still essentially a privately delivered process. Canadians don't seem to recognize that. Hospitals like my hospital is privately owned. It's publicly funded, but privately owned. So we are constantly constrained by that envelope of funding, but fortunately in Toronto, being the city it is, we have opportunities to innovate in fundraising and so forth to give us a little more freeway. One area that I have struggled with is the very bureaucratic and fragmented management of funding in healthcare. And I still struggle with having provincial budgets. Now, I may be simply naive about this, but I see, say, Prince Edward Island having a drug approval process where Ontario, log factors of the population, and why we repeat all these things, I don't understand. Our hospital, as in most hospitals, gets the bulk, not all, but 70, 80% of its funding from the provincial government. And that's a process that is extremely painful to apply for, to audit. I recently, to give you a little vignette, had a subway fare in San Francisco turned down on a meeting expense because I didn't have the receipt from the machine where I put my money in. It was $12 instead of a $50 cab ride, which I chose to do specifically for that. Well, amount of time spent trying to find a receipt for that, I eventually just, wrote it off. But it's a mini example of the kind of bureaucracy. What I would really like to talk about is the physicians need to be more engaged in solution finding here. And rather than look the problems and complain about it, and I don't mean anybody on this panel, but when I watch my patients, the biggest disparity I see is the patient healthcare who comes to understand the issues and takes action, whether it be background reading, asking the right questions, accessing patient advocacy groups, looking at decision aids in making their decisions, that sort of thing, compared to the patient who either by choice doesn't want to do that or doesn't have the ability to do that. So we've moved in Canada to what has been called patient-centered care to a large degree, probably more than other countries have in North America and in the Americas. But we have not really exploited this as we might. And physicians don't, I think, embrace the opportunities here. And talking about innovation, the physician needs to reflect on whether or not they can do things differently to deal with these problems. I'll give you a little example of this. Not so long ago, there was a study where half of patients with advanced cancer on systemic therapies, chemotherapy, half of them were given an opportunity for direct access to a nurse specialist 24/7. And they could report toxicities of their treatment, and whether it was Saturday night or Thursday noon. And they were given a program of education about their treatment and the drugs, etc. Those patients they got the same treatment, same drugs, they had the same types of cancer, and this isn't one or two patients, this is hundreds of patients. The patients who had that opportunity to be engaged in their care had an overall survival advantage that would exceed the benefit of a blockbuster drug. If Pfizer had developed a new pill for that cancer, they would make billions of dollars selling it if they could improve survival by 5%, let alone 10 or 15%, which was in fact what has patients who had the opportunity to be engaged in their care. So just an example of innovation, I would say that while physicians are, and I don't mean just physicians, clinicians in general, nursing and the other healthcare providers, if they saw this aspect of patient care like they see doing a hemoglobin blood test, a referral to advocacy groups to fund in a very minimal way these patient groups who are led by extremely intelligent people who bring their life skills to helping others. And it doesn't cost very much to do this. And when the patient comes to the clinic or the hospital, or more importantly, when they learn how they don't have to come to get access, and I'll talk about that possibly later, then they are going to be better prepared, and they are going to actually take less physician time And if you look at a clinic of 30 or 40 people, you probably could weed out a third of those visits simply by this preventative approach to their care. You know, there's an example. I haven't directly answered your question, Jeff, but I just wanted to have people realize things are all not doom and gloom. We have also opportunities here, and redirecting some of our support, we could harvest some of these things. What's called disruptive technologies in other industries is remarkably not happening in healthcare.
I think that's a very important observation. I we'll talk a bit more about it later, but you're absolutely right. Involving patients is so important, and I get so tired of seeing all these posters around hospitals saying we're patient-centered, and they're not. They're no more patient-centered than they're automobile-centered. That hasn't really happened. I've actually been watching aggressive attitudes to patients that embarrass me, and leaving patients in waiting rooms for hours. And this is not for not because a trauma surgeon's called into an operation urgently. It's an oncologist, for God's sake, who's running an office and is 3 hours late. That's not good enough. So we need the involvement you're talking about, real patient-focused or customer-focused, I think has huge potential, and we will come back to that. I want to return to Wayne, and I didn't introduce Dr. Wayne Marshall properly originally. He's executive director of the UHN Osteoarthritis Society, but he's also quite an entrepreneur. Wayne, do you want to just take 30 seconds to tell us about some of your activities before you answer the question, which I think follows on from Michael's? Is medicine and treatment moving from a one-size-fits-all model to a more customized approach, which is a topic that's popular at the moment? Wayne.
Thanks, Jeff. I guess I've seen this issue from multiple different perspectives. One is as a orthopedic surgeon who focuses on knee problems, primarily minimally invasively with arthroscopic surgery and injectable techniques, and then as a basic scientist, and then also more on the business side from being an entrepreneur, and I'll weave some of this narrative into the answer. There's no question that with our improved understanding of molecular biology over the last couple of decades, that, as Michael said, this is really an immensely exciting time in science and in medicine, because we're beginning to understand disease in a way that was just unthinkable a few decades ago. And so with that new knowledge, we are being able to understand our patients as individuals much more than we've been able to in the past. And we are getting away from the one size fits all, although I would still say that that's more the norm than an individualized approach, but we are making progress. And a lot of that's been related to advances in imaging techniques, things like improvements in resolution with MR scanners, PET scanners, the development of molecular biomarkers, particularly in the cancer area, where we can begin to identify the behavior of tumors at a much better level than we could before, and we can begin to have therapies that are very directly targeted to the pathophysiology behavior of a specific tumor. So we have made a lot of progress, but I think that that's the exciting part. I guess the part that I find frustrating is I've had a number of differing interactions with the healthcare decision makers in the ministry over the years, and I've learned how they think, and it concerns me about our ability to be able to incorporate these innovations. I mean, first of all, we've got a huge problem because, as the overarching theme of this presentation is, you know, we are underfunded in our healthcare system for our current technologies, let alone how do we begin to integrate innovative new diagnostics and therapeutics and other technologies that are becoming available. And a number of years ago, I was involved in a submission to the ministry around a new injectable for osteoarthritis. And we'd gone through a very comprehensive health economic study in which we were able to demonstrate to the payers that they would get good bang for their buck, that ultimately they would save money down the road with less surgical interventions. And I thought this would be a no-brainer that they would be prepared to fund this particular new treatment. And that's when I learned a really important political lesson. They were interested in managing to the next election. So the cost of incorporating this new technology would have increased costs in the short term, and the savings would have been realized many years down the road on somebody else's watch. So there wasn't a great deal of enthusiasm for taking a long-term view of our healthcare. It was really more a matter of managing to the next election. The second example is a situation in which we were trying to apply to a special technology fund to get a special research MRI at UHN. And this was at a time when there were only 3 MR scanners in Toronto. There were about 160 in San Francisco at that time, similar metropolitan area. And so we felt that the Ministry of Health would support us because they'd basically get a free scanner if this was funded out of somebody else's wallet. And we would have research from 9 to 5, and the other 2 shifts would be a freebie to the Ministry of Health. And they came out and opposed the funding of this. And the rationale for it was that MR was an unproven technology. Now, this is when MR had a decade of experience around the world and was a gold standard. So again, I started to see that the strategy of the bureaucrats is that, well, if you say something doesn't work, then you don't have to go through the hard process of saying, so how much of this do we need? How are we going to fund it? Where are the other trade-offs? So there's this, and I've been involved in some other situations where there are things that are approved by Health Canada, but they're not covered by the Ministry of Health. So here's level 1 evidence. It's safe, it's efficacious, it's a very rigorous process to get regulatory approval. But the response from the ministry will be, well, we need more data, it's not proven. So I think that there needs to be a fundamental change in how we look at incorporating innovation into our healthcare system, and also taking a much longer term view, making some investments today that may cost us more today, but will help us 10 or 20 years down the road. But it really seems today, like to a large extent, our healthcare system by the political masters is being run in order to spend the least amount of money that can get you away without having an embarrassing article on the front page of the Star of the Globe. And that's just no way to run a healthcare system. One last story I'd like to share. One other part of my life, I'm involved in developing a novel treatment that's a polymer that will be able to put in knee joints at the end of total knee surgery. And today, total knee replacement in the hands of the most expert surgeons with really good quality physiotherapy has about a 20% patient dissatisfaction rate. And not that anybody does anything wrong, it's just a really big operation for patients to go through. And the FDA has looked at surgery as a potential gateway to opioid addiction, huge problem in the US and a significant problem here. And they found that total knee replacement of all the surgeries that are performed in the human body has a highest requirement for opioid prescriptions, and other data showing a 15% opioid addiction rate in patients undergoing elective total knee in the US. So the product we're developing allows us to put a polymer into the joint at the end of a total knee replacement and have slow, sustained release of an anti-inflammatory drug, celecoxib. And we've been able to demonstrate in phase 2 trials in the US that we can diminish pain and diminish opioid consumption by 40 to 50% through a period of 6 weeks. So this is like a really important innovation that can really help get better outcomes. But we're not doing trials in Canada, we're doing our trials in the US. And the reason for that is that, as a Canadian, I want to see this product in Canada. The problem is that this product will never be funded by ministries of health in Canada because right now they don't have the money to take in new innovations. And so as much as I would like to be introducing this product in Canada, it'll inevitably wind up in the US, maybe eventually gets here someday. But from a business point of view, you could never hope to innovate into the Canadian healthcare system with something like this, because it'll just never be reimbursed and it'll wind up being a failure. So, we really have to fundamentally rethink our approach to how are we going to begin to incorporate these new innovations that will get us to a more of a customized approach to managing healthcare, get away from the one size fits all. But that's not going to be realized unless we figure out how we can judge which things we should be paying for and how we're going to pay for them.
Yeah, I think we've all got stories that relate to trying to introduce new technologies, and we're gonna talk about more about that later with Walter, because it's not only the approval of new methods, but it's also our capital funding is falling behind. Our operating costs are going up all the time, but capital investment is actually dropping.